All right, we know that the ideal total knee arthroplasty should provide maximum range of motion and functional stability for all desired daily activities and must replicate the normal knee kinematics and function, and we heard a lot about it all this morning. The medial pivot, I don't touch anything. The medial pivot knee system is designed with a highly congruent medial compartment and less conforming lateral compartment to more closely mimic the kinematics of the normal knee and to offer more stability throughout the range of motion. This was the argument when my good friend, bioengineer Kyriakos Pentzos and David Blaha came to me to ask me to start using the medial pivot. And I started at the beginning of 1998. That means April of 1998. I may be the first one in Europe. Maybe our good friend Lagaste is close, and my long-standing good friend Theophilos. So we collected the data of 350 patients, 385 knees, male and female, and you see the reason. It was mainly osteoarthritis of the knee. Something goes wrong or something I do wrong. Okay, the same surgeon as me, the standard medial midline approach, medial parapatellar exposure. And this is something we're going to discuss a little bit later. The posterior cruciate ligament was retained in about 53% of the knees because it was early days. We didn't have much experience about the stability of the knee. So if the posterior cruciate didn't bother us, we just left alone. And we used cemented technique and patellar non-replaced, just denervation and remove the osteophytes. Clinical evaluation, the American Knee Society score, the Oxford Knee score, the WOMAC, radiological evaluation, component alignment, osteolysis, implant loosening, and subjective patient assessment and satisfaction. The mean follow-up, it's 20 years, minimum 20 years. It's up to 24 years. Of course, we lost some patients. Some of them died, and some of them did not appear. And we had 7 cases of revision, 3 cases for the tibial component loosening, subsidence. At the beginning, it was the problem with the mismatch between the femoral and the tibial component, not many sizes. The evolution now has solved this problem, but in the early days, some of the tibial trays were smaller and we didn't have the possibility to take advantage of the cortical bone, and they were sitting on spongiosa, so we had some subsidence, and we had to revise, and some classical persistent anterior knee pain and periprosthetic tibial fracture. And these are our results, or about the American Knee Society score, the Oxford Knee score, the SF12, good improvement, the WOMAC, the surgery fulfilling expectation of the patients. And this is important because 82% of the patients, they had excellent relief of pain. Of course, there are some patients, they complain of pain. We don't know exactly why they complain, but any kind of surgery you do, any kind of implant you use, you will have some unsatisfied patient. We heard about this morning. 94% were able to perform regular activities because the majority of the patients, they want to do the daily activities, and they were able to perform heavy manual work. Some of them, they were younger patients, and some of them, they want to participate to sport activities, despite the fact that you tell them do not do any sports, they do. And they had 73% excellent comfort during walking. You see here what it's defining about the posterior cruciate ligament retaining. You lose some of the flexion. So based on those data, today we sacrifice the posterior cruciate in all knees, even if it doesn't bother us, because we believe that our medial pivot is a PS knee and we behave like that. So we sacrifice based on this observation. And some of the data, again, some of the progressive radiolucent lines. I mentioned already that we had to revise some tibial components because of the shrinkage, and there have been some radiolucent lines. They are not a risk, they don't complain, the patients, but still exist. What about the survival? If you use the revision surgery as endpoint, the survival rate is 98%. So I mentioned about tibial subsidence, persistent anterior knee pain, one lower patellar pole fracture. It was kind of avulsion, conservative treatment. I'll show you the X-ray of that. Periprosthetic tibial fracture, superficial wound infection, wound hematomas, DVTs, and pulmonary embolism. That it was the kind of complications we had in this series. And we published our results. And in conclusion, we believe that a medial pivot, it is an excellent solution for total knee replacement. This is a long series, and throughout the years, we have learned that we should keep the medial compartment tight. We should have the knee a little bit looser in flexion, but we should have into consideration and should keep in mind that throughout the years we learn how to use the medial pivot concept, and today we have all the details and many data to have even better results for the future. I thank you for your attention. Oh, so I want to show you some of the cases, sorry, forgotten. So some of the old cases, you see in the old days, they had this metal piece over there, and this is 10 years follow-up. This is the case with the patella, pole, the avulsion. Now we did just conservative treatment. Another case, 20 years follow-up. You don't see that much wear of the poly. There is some demarcation line in the medial side, but the component's absolutely stable. It's 20 years follow-up. I don't think we could expect any better. Thank you very much for your attention.